Hello, today we would like to have a chat about convalescent plasma administration in COVID-19 patients and see how we could consider it in the management of the critically ill. And from there, of course, we will go to monoclonal antibodies. And to discuss it with us, we have great experts, Geert Meffroy from Leuven and Benoît Misset from Liège. They are both PIs of two important Belgian studies on this. And we have Michel Goldman, who is an international expert in immunology and very much involved at the European level, and he will put it together at the end. So, we started this because of the Lipster's study published in the New England Journal a few days ago. This study performed in Argentina, showing in 160 elderly patients that plasma administration could actually be helpful and could limit the progression towards severe respiratory failure as defined by tachypnea and or hypoxemia. So I will ask Geert and Benoît first to say what they think about this study. Is it important? Is it definitive? How do you put it together with the other studies that we have available on this? Geert?
Yes, thank you, Jean-Louis. Yes, for me, it is hopeful, of course, that we have a subgroup of patients where there is a signal. I think the endpoint of the study is, of course, disease progression, which is not a very strong and hard endpoint. And for instance, on mortality of length of stay, we would have preferred to see that. We haven't seen that. There's a small imbalance also in age between the two groups, in the control and the intervention group. In the placebo group, there are a bit more elderly patients because they concentrated on the elderly, but then they allowed, so above 75 years old, but they also allowed between 65 and 75 with comorbidity. So there is some imbalance between the two groups. So okay. I definitely do not consider this as the final evidence, but I think it supports the hypothesis of our trial, the Down plasma trial, which we will come to, that an early intervention is probably more useful than a late intervention, because if you are late, the patient already has antibodies, and that it needs to be a high dose, which is what both Belgian studies do.
They tried indeed to have all the potential advantages to find a positive results. These patients were really elderly, 77 years of age as a mean, and indeed they intervened very early. 77 years of age, some people could not sign the informed consent because of some dementia. So they were really old. Benoît, do you agree?
Yes, I would add 2 points. The good thing for me is that this is the first randomized control trial which is positive, because there have been already 2 or 3 RCTs published, and this is the first one which is positive, which is a good signal. And the second point I would say is that those patients are not really those patients that we have usually in the ICU. So the authors addressed mild disease with before 72 hours after the onset of the disease, which is not really what we see usually in our units in practice. And of course, the mortality also was really low. So that is very interesting, but probably it's not really the population that we are used to see in our units.
Yeah. Michel Goldman, already a short comment at this point about the early intervention and the age, maybe?
Perhaps about the early intervention. I think it's rather clear now that in addition to vaccines, we have to focus our efforts on early intervention strategies. And so far, I see 2 or 3 of those. You have one which is related to the interferon type 1 in inhaled form. Another strategy is based on an antiviral, which is just under development, but we don't know enough yet. And the third...
Not remdesivir. Are you speaking about remdesivir? No.
No, it's another one. I will give you the name in a moment. But the idea, actually, this drug was approved yesterday, is to have something like Xofluza for flu. You know that Xofluza was approved yesterday for flu to be given, in the very early days, even to high-risk contact persons of people with flu. And the third approach is indeed to use immunotherapy, either in the form of plasma, which is the discussion. Personally, I think that it will be very difficult to develop on a large scale. Monoclonal antibodies might be...
We'll speak about the monoclonal antibodies in just a moment. Maybe Geert can speak about this trial because it's progressing well. More than 400 patients already in that trial.
We are almost there. So less than 20 patients to go, which would be at the peak of the pandemic, this would be in less than 2 days. Now it's probably going to be 2 weeks from now. And we plan to have our endpoint at 28 days. So this means that after conclusion of the trials, it will take another month. So probably end of February would be the earliest that we can have the results. We decided to find, so we didn't do interim analysis for futility. We only did it for safety. We had 2 ESMBs for safety, and we were allowed to continue. But we decided to make to make the study to an end.
Can you comment on the mean age or the median age of the patients or not?
No, but it's a typical profile of what we see in the hospital. So it's with an average, so it's the typical male person with an average age around 60 years old.
Okay, so it's younger than in the Argentinian study.
Younger than in the Argentinian trial, and it's also mostly non-ICU patients, of course, because our intervention is early in non-ventilated patients, early in the hospitalization. So for the ICU patients, it's more the confident trial by Benoit.
Sure. Benoit, yeah, sure.
I have a question on the 2 PI, of course, more on the methodology, because we will discuss, Geert has done a discussion on his trial, Benoit will discuss the other one on ICU patients. I wonder whether you can comment on 2 issues that in general are true for plasma studies. First is the titer of plasma. In this New England paper, they clearly stated in the title, high titer plasma. And maybe this is one of the limits for the previous study where the titer was not really assessed.
Correct.
And the second point is about, Geert mentioned not interim analysis. What about the numbers? Because we observed these large studies from the Remap platform, from recovery with more than 1,000 patients per arm. Do you think that going for 400, 500 patients in COVID-19, even in selected patient population, would be realistic in terms of outcome?
Yeah, so we go for 500 patients. I think it's important to have these numbers. So I prefer the larger study because I think this is, as I said, this is not a very hard endpoint that they have chosen for this trial. So I think that's a bit of a problem. For us, it's mechanical ventilation, the endpoint. I will comment briefly on the titers. It's very difficult to compare these titers because a lot of studies use different methods and even different types of antibodies that they go for. Because we go for a titer of 1/320 neutralizing antibodies and NT50 in all the bags. We've been close to that, but some of the bags at 1/160. Here, this is specific IgG titers against the spike protein, so that's not completely comparable to what we have. I know that about a quarter, 20% of the donors have high enough titers for both of our studies, because Benoit's study has the same levels that he requires.
Okay, Michel, any comment about the titers? No? No, you are on mute. You're on mute.
I think titers are important. I think that we should also realize that most tests that we are using are not directly evaluating the neutralizing capacity. So for large-scale deployment, this might be a limitation.
Okay. Benoit, you wanted to focus on ICU patients. Isn't it too late, you think?
I don't know if it is too late. That the trial that we have started is the Confident trial. It addresses the efficacy of convalescent plasma in mechanically ventilated patients, principally because there was absolutely no study in those patients, and that we ICU physicians had to have to test something in this disease at this time. We decided to include all the consecutive patients who were mechanically ventilated for less than 5 days, and to stratify the randomization by 48 hours, before and after 48 hours, to have a result.
Yeah, okay, we have no time to go into the details, but some people may think it's quite late when you are already in the ICU.
Yeah, yes, it may be too late. That's for sure.
Who knows? We will see.
That many patients, I don't know exactly the proportion of them. Many patients have still high levels of viral load, and maybe that's not so. That's maybe interesting in those patients with high viral load. This point we will.
Very good. We have 3 minutes left. Fabio Remap, they just announced that they abandoned this route.
Well, as I mentioned, we heard from the Twitter, which is now the best way to communicate, that they interrupted immunoglobulins, and in the same thread, they said that there was no effect of convalescent plasma compared to control. So we have other internet-based information, not published information about the plasma, which is a little bit complicated to address, to evaluate in comparison with the studies that have been published. That's my point of view. I don't think we can say much more because the data are not being presented. So
no, sure. Okay, Michel Goldman, how can we put it together, and what about monoclonal antibodies?
Yes, what I would like to do, because time is short, 2 major thoughts. First, it's really critical that we develop tools to identify those patients in the early phase which might develop severe disease. Because obviously we cannot give either convalescent plasma or monoclonal to everyone just after the diagnosis. And that's where I think that artificial intelligence has a very important role to play in trying to identify those patients and treat them early. Second remark is about the potential risk related to either convalescent plasma or monoclonal, which is to give an advantage to some variants, to some mutants of the virus. And there is preliminary observation in immunocompromised patients actually receiving convalescent plasma that this might promote the emergence of this more dangerous virus. And I think that when we consider all these immunotherapies, we should be prepared to discuss and explain what we are doing to prevent as much as we can these drawbacks.
Good. So, Geert, are you concerned about potential negative effects, harmful effects of plasma administration?
Yeah, I'm pretty confident about the safety of the therapy. I think this has been demonstrated in a lot of studies before for other conditions as well, that it's a safe therapy. Of course, efficacy, we do not know. And as a clinician, of course, I'm not neutral to the result because I would be very happy that it would work. As a scientist, I must say I am neutral to the results, and we will see. I'm sure, because there's no study to my knowledge that gives such a high dose of plasma worldwide. So I think we have a good chance of, if there's an effect or a signal, to pick it up, but we will see. We will see what the analysis brings.
Mm-hmm. Michel Goldman, the last words about the availability of all this, because you alluded to the difficulty to give it very widely to many patients. So in the future, shall we find more plasma or more antibodies? What is the future? Is it brighter for plasma or is it brighter for monoclonals?
Well, we all have our bias. So I personally think that monoclonal antibodies will be easier, obviously, to deploy because you don't have, all the hurdles related to, collection of plasma from donors. Also in terms of standardization, there you don't have to measure the titers to measure the neutralizing activity. So I think that from a practical point of view, I anticipate that monoclonal will be easier to deploy, but the problem is still the manufacturing capacities of the companies as well as the cost.
Yeah, and the
Very
setting,
good.
I think developing countries, for developing countries or less resource-rich environments, plasma would be a good solution if it works.
Yeah.
Yeah.
Important comment.
Fabio, last comment? No?
No, I don't have any other comment, just waiting for the results of our Belgian ongoing studies, hoping that they will give some insight on how to manage these COVID-19 patients.
Absolutely. It's great to see that Belgium is in good place for all this. And let's be optimistic and let's hope for other strategies for COVID, but we will speak about it at other occasions. So many thanks to all of you, and we'll see you later. Bye.
Thank you.
Bye-bye.
Bye.